Good afternoon, everybody. Thank you, Dr. Khanna, and thank you, chairpersons. My topic is the tips and tricks in femoral and iliac intervention, and especially for the beginners. A beginner should not be over-enthusiastic and overconfident, but at the same time, he should not estimate himself, underestimate. Angiography is a general term that describes the radiological examination of the vascular structure within the body after the introduction of an iodinated contrast medium or gas. And it should be very clear, should make the attendants very clear that this is a test only. Angiography is a test, it is not the treatment. The contraindication for the angiography is the previous severe reaction to contrast, impaired renal function, and impaired blood clotting factors. Should have the thorough knowledge of the arterial tree. The indications for the iliac and the femoral intervention to relieve symptomatic lower extremity ischemia includes lifestyle limiting or progressive claudication, ischemic pain at rest, non-healing ischemic ulcerations, and gangrene. The vascular access for the iliac angiography may be obtained from the upper extremity or the lower extremity. The most common used is the lower extremity. 4 potential routes of the access to the iliac and the femoral lesions. It may be a contralateral femoral retrograde access. It may be ipsilateral femoral antegrade access. It may be ipsilateral popliteal retrograde access, or it may be a brachial retrograde access. The retrograde common femoral artery access, the common access site used for the peripheral diagnostic angiography and the intervention, prevent injury to the less diseased extremity. The contralateral femoral retrograde access, the iliac occlusions are best treated from a contralateral approach. The CFA, superficial femoral artery, profunda femoris artery lesions involving SFA oblique the PFA ostium, and allows treatment of bilateral disease with a single arterial puncture. The prerequisite for the vascular access is relatively disease-free artery without significant calcification. It should be over a bony structure, that is femoral head, if possible, and angle of the entry must be 30 to 45 degree. Behind the artery, it should be a hard structure to give the pressure after the procedure is over. So here we can see this should be the puncture site where we have a hard structure just behind the artery. The vascular access technique, using a standard Seldinger technique, arterial access is obtained. The desired vessel is punctured with a sharp hollow needle called a trocar with ultrasound guidance if necessary, where you can't palpate a artery, especially in the iliac occlusions. A round-tipped guide wire is then advanced through the lumen of the trocar and the trocar is withdrawn. A sheath or the blunt cannula can now be passed over the guide wire into the vessel. 4 French to 6 French vascular sheath is inserted. Sheath flushed and 5,000 international units heparin administration is done via sheath to prevent the clot formation during the procedure inside the sheath itself. This is the pictorial presentation what I have told. And once we see the free flow through this needle, then only we can see that our needle tip is inside the lumen. The equipment for the intervention is sheath, guide wires, balloon, and stents. These are the different type of the sheath or different sizes. The vascular sheath is this allow for the easy exchange and the introduction of the catheter and guide wire. They have a hemostatic valve that prevents blood reflux and air embolism. Furthermore, they protect the vessel entry point from intimal injury and should be used whenever multiple guide wire exchange are anticipated. Sizing of the sheath is based on their internal diameter. A 7 French sheath will accept up to a 7 French catheter. In addition, the side port of the sheath can be used to inject contrast or measure arterial pressure. So, all sheaths are packaged with the dilators. Dilators serve as an obturator for entry of the sheath and also help to progressively enlarge the tract once guide bar entry has been established. The guiding catheters in the sheath can be used to facilitate passage of a smaller endovascular device through a tortuous curve. They are particularly useful in the renal and carotid system or the contralateral iliac system. These are the different types of the catheter according to the need and the use. An ideal catheter should be able to sustain high pressure injections, to track well, be non-thrombogenic, have good memory, and should torque well. Length depends on the location for using, and sizes are 5 to 8 French. For the abdominal aorta, 60 to 80 centimeter length is sufficient. These are the catheters. These are the types of the catheters. A catheter should have the properties. It should be hydrophilic coated catheter, hydrophilic coated distal tip, double braided stainless steel mesh, middle layer, increased shaft rigidity and torque transmission. This is a sleep catheter, very useful. Sleep catheter is a hydrophilic, has a hydrophilic coating, enhanced radio opaque beacon tip. 16 stainless steel wire braid imparts 1:1 torque control to catheter tip and increase pushability, and nylon material resists softening during prolonged catheter manipulation. These are the different types of balloon, different lengths, different diameters according to the need and the use. The balloon, in selecting a balloon, the following criteria should be considered. Over which guide bar our balloon will be placed, over the wire or the monorail system, and the length of the shaft. Balloon shaft lengths are commonly 75 centimeter or 120 centimeter, can be coaxial or monorail, and designed to be inserted over O14 in O18 or O35. The balloon size and length is matched to the size 5 to 6 millimeter. And the lesion length is 40 to 300 millimeter of the lesion. Improved angiographic results may be accomplished with prolonged inflation times, 3 to 5 minutes. Dissections are commonly seen after balloon dilatation due to heavy calcification. The diameter matching vessels beyond lesion. Balloon length should be more than lesion. Balloon centered on lesion and inflated slowly. Inflation maintained for 20 seconds, deflated, reinflated, and the 3 inflations of 20 seconds. These are the different sizes of the balloon. And these are the stents. After every angioplasty, there is not need of putting the stent in every lesion. The vascular stents are metal frameworks that support the lumen from within. The types of the stents are self-expandable, as it is self-explanatory. As soon as it comes in the contact with the blood, it expands. The balloon expandable, bare stent, covered stent, and drug-eluting stent. This is a self-expandable stent. As the name implies, the self-expanding stents are released from their constraining delivery mechanism and expand within the vessel until the stent reaches its predetermined maximum diameter or is constrained by the vessel wall. Basic configuration includes spiral and mesh. This is self-expandable stent. Self-expandable stents deployed in the vessel, there are flexible or twist during movements. Nitinol metal provides best flexibility and memory. A stent is simply compressed over a stent delivery catheter and covered with a sheath. A stent deployment is achieved by pulling back the sheath. A stent diameter should be 1 to 2 millimeter larger than the reference vessel diameter. Adequate stent apposition with the vessel wall. The self-expandable stent, some degree of the foreshortening to be taken into account when choosing. More difficult to place with absolute precision. Generally comes in longer length than balloon mounted stent, and their ability to continually expand after delivery allows them to accommodate adjacent vessel of the different sizes. These are the balloon expandable stents. Balloon expandable stents rely on inflation of an angioplasty balloon to expand the stent from its collapsed configuration and push it into contact with the vessel wall. Most contemporary stents are factory mounted on the balloon. Require positive pressure for expansion, typically rigid with high radial force, and size of the balloon expandable stents equal to the size of the reference vessel diameter. These are the balloon expandable stent. Self-expandable versus the these are some advantage and the disadvantages. These are the bare stent, and these are the covered stent. In the covered stent and the stent grafts are the terms loosely used to describe metal stents that are either covered or lined with fabric, usually polytetrafluoroethylene, this PTFE, the same material of which we use the graft. Examples include the lined Viabahn, which is FDA approved for the superficial femoral artery. The addition of the fabric means a larger delivery system is involved. Benefits include the ability to treat aneurysm and the perforations while maintaining lumen patency. These are the drug-eluting stents. The most recent and the dramatic advance in the stent design is the drug-eluting stent. These stents provide local release of a drug to prevent restenosis. Agents used include the anti-proliferative drugs, the sirolimus and the paclitaxel. FDA approved for use since 2003, they have become popular with substantially lower stenosis rates than bare metal stents. However, they are expensive and the patient must remain on clopidogrel for 6 months after placement to prevent thrombosis. These are the drug-eluting stents. The complications are with an overall incidence of 1.5 to 9%. Peripheral vascular complications include, in descending order of frequency, the perforation of main artery, perforation of a side branch leading to hematomas, thrombus embolization from catheter or wire or air embolization, and cholesterol emboli or atheromatous embolization. The complications may occur in timal dissection, pseudoaneurysms, AV fistula, acute arterial occlusions, stent fractures, especially in stent overlap, and in stent restenosis. In long stenting segment, multiple stents. Thank you very much.
Thank you, Mr. Sandeep. Do you have any question? We have a little discussion. If no, some discussion. I have a question. Who usually train the youngest generation in endovascular technique in the Indian hospital? Who is doing the training? Surgeon, cardiologist, radiologist? What's the cursus?
Everybody. Yes. Everybody.
Who is doing? Who is training the people? The professor, the doctor, the vascular surgeon? Please.
No, it depends upon what training you are in. Like if you are a cardiology trainer, then you will be trained by a cardiologist.
Tell me how can we be trained in India, in Mumbai?
In Mumbai?
In Mumbai. By whom?
By the professor, whoever is the senior, who is a doctor.
So
in India,
you are trained by the professor.
Yeah, in India, interventional cardiology in peripheral vascular disease is done by cardiologists, is done by radiologists.
How long is the
done by vascular
training?
surgeons.
How long is the training before being to have the license to operate?
National board has a FNB intervention cardiology course of
No,
2 years.
we have the DNB course full-fledged for the 3 years, and there are 2 seats in our hospital. Overall, in the country, there are 10 seats approved by the National Board of Examination, and we train surgery as well as endovascular surgery.
How many fellows are in this room? Are you a fellow?
No, no.
So 1, 2, 3, 4, 5. So next question, do you have any other question? No.